rules, I'm sure you're all familiar. So we'll move on to the first question. So the first question is, when is a repeat renal biopsy indicated in a patient with suspected lupus nephritis flare as emphasized by KDIGO 2024? Option A, when proteinuria exceeds 3 gram per day regardless of renal function. B, when there is diagnostic uncertainty regarding active disease versus chronic damage with unexplained worsening of renal function. C, whenever the patient has a sudden increase in anti-dsDNA antibody level or sudden low complement levels. D, when there is a failure of 2 consecutive courses of immunosuppressive therapy. Now, Dinesh, please launch the poll. So once the poll is launched, you can answer. Yes, your time starts now and you have 30 seconds with you to answer the question. Okay, I think time is up. Dinesh, you can close the poll and launch the result. So you can see the majority are of the option that when there is diagnostic uncertainty regarding active disease versus chronic damage with unexplained worsening of renal function. In fact, that's the correct answer. We'll hear from our expert panelist, Dr. Edwin, sir, more on this question and the answer. So over to you, Dr. Edwin, sir, for discussion.
Thank you, Jyothipriya. So the repeat renal biopsy, please remember that the renal biopsy in a lupus nephritis gives static information about a very dynamic process. So a biopsy done at one particular point of time gives you the information at that point of time. And we know that lupus has its flares, it has its remissions, it has its relapses, etc. So when the first option here, the proteinuria exceeds 3 grams regardless of renal function, may not be the right option. Number 2, the B, when there's a diagnostic uncertainty regarding active disease versus chronic damage. When there's worsening of renal function, you think whether there could be a nephritic flare or a crescentic GN that could happen, or when there is increased activity of the disease. For example, a worsening of a class 4 or a class 5 or a class 3 to class 4. Then you have a problem where when there's unexplained worsening of renal function and you think that I have treated this patient sufficiently well, maybe the proteinuria that is increasing is because of underlying worsening of kidney function, sclerosed glomeruli putting out that amount of proteinuria. So before we go to the next step of upscaling our immunosuppression, we need to know whether this is an active disease or there's a chronic damage. So there, biopsy, it's just for probably even a negative reason that you decide not to immunosuppress further and take care with the renoprotective agents. The option C, whenever the patient has sudden increase in anti-dsDNA antibody or sudden low complement levels, these are things that we normally don't check. See, normally when we sit in the outpatient department, we look at the urine protein. You look at the urine PCR, urine routine, and then the creatinine. So this is what we normally do and check the blood pressure. So we wouldn't do a anti-dsDNA antibody level screening or complement level screening. We would go clinically by the urine routine. So that may not be the right answer. When there's a failure of 2 consecutive courses of immunosuppressive therapy, yes, partially this may be a reason because there is an explanation in B itself regarding this. So there is a failure of therapy. We are not sure whether there is a class switch from, let's say, class 2 to 5 or a 4 has gone to 5. Or, if there is a possibility that should I further immunosuppress my patient or should I stop here, do a biopsy and then check. So D is maybe partially right. More of a reason, a negative reason for not a negative biopsy, I would say, to not to upscale my immunosuppression. So, but I think B would be the right answer, as most of the people have voted for. Thank you, Jyothipriya.
Thank you, sir. So moving on to the second quiz. A 28-year-old lady with biopsy-proven class 4 lupus nephritis on mycophenolate mefetyl and low-dose prednisolone presented with 7 days of fever and non-productive cough followed by 2 days of progressive dyspnea. On examination, she is tachypnic with bilateral basal crackles. Chest radiograph shows bilateral diffuse alveolar infiltrates. Lab investigations reveal ESR of 82 millimeter per hour, CRP 2 milligram per liter, which is normal. Complement C3 and C4 are low. Anti-dsDNA titer markedly elevated. So which of the following options best explains the discordance between the markedly elevated ESR and normal CRP and thereby supports the most likely diagnosis? So the options are A, IL-6 mediated hepatic CRP synthesis is suppressed during lupus flare. B, type 1 interferon mediated suppression of hepatocyte CRP synthesis despite active systemic inflammation. C, ESR is a more specific marker of bacterial infection than CRP. D, CRP is rapidly consumed at inflamed pulmonary tissue resulting in low serum concentrations. Dinesh, please launch the poll. So your time starts now. You'll be having 30 seconds to answer this question. You can type your options in the chat box. I think time is up. Dinesh, you can close the poll and launch the result. So 20% have opted for the first option and majority are of the opinion type 1 interferon mediated suppression of hepatocyte CRP synthesis despite active systemic inflammation. In fact, that's the correct answer. So we'll just move on to the explanation part. See, this is a classic ESR CRP discordance seen in active SLE, particularly during lupus flare. In active SLE, especially in lupus pneumonitis, ESR is often elevated while CRP remains normal or only mildly elevated. So this is because type 1 interferons, especially interferon alpha, which are highly expressed in SLE, which got elevated during flare, suppresses the CRP synthesis by hepatocytes in the liver, blunting the CRP response despite active inflammation. So therefore, CRP may remain surprisingly low. Now, so this pattern of very high ESR, normal or low CRP with low C3, C4 and markedly elevated anti-dsDNA strongly supports the active lupus or lupus flare. Now, regarding the other option, if you take option A, IL-6 mediated hepatic CRP synthesis is enhanced in fact, but because of the enhanced interferon alpha synthesis in SLE during flare, this interferon alpha can inhibit the IL-6 induced CRP gene transcription and CRP secretion by hepatocytes. And regarding the next option, ESR, neither ESR nor CRP is specific for bacterial infection, and CRP is regarding the last option, CRP being rapidly consumed at the inflamed pulmonary tissue, which is not the right answer. The low level in SLE, the CRP level is low, is primarily related to the altered hepatic production.